if you got our email reminder, you know that today we are talking about NGRI. We have Christy Granger from CEICMH here to talk about it, as well as Dr. Scott Smith to talk about processes, procedures, and practices, everyone's favorite alliteration surrounding NGRI. So yeah, as I said, NGRI continues to be a vexing topic for a lot of professionals and presents a lot of different things to navigate. So as a center, we want to make sure that we're curating a space for professionals to come and ask their questions and learn and address the barriers that they encounter. So before I kick it over to Christy and Scott, there's a couple of just housekeeping items that I like to address, every single time we do this and we meet every month. So just wanted to give you all a heads up that SCAO has updated the PCM 208 report on examination and the clinical certificate. The main change is that the form now gives clinicians a spot to show if someone who meets the criteria as a person requiring treatment has chosen to accept the treatment voluntarily. So you can use the old version of PCM 208 until October 11th, but starting October 12th, 2025 of this year, the new version will be required. So please share this with the hospitals that you work with. Yeah. So also, every month I have to plug our Q&A sessions, especially because I see that there are new people here that haven't been here. Welcome to our community of practice. So twice a month, we have Dr. Scott Smith available for a Q&A session. He's able to answer any AOT related questions. So anyone can come to these sessions. It's kind of like a drop-in kind of situation. So you don't have to come in right on time, but anytime within that hour span. So we hold that twice a month. And it's also a great resource to share with families and loved ones and natural supports of AOT consumers if they have questions of their own, and they need support in education in that way. So as AOT gets more attention across the state, more and more questions are going to arise. So again, this is, a different kind of space that we want to curate to make sure, we're providing space for those questions to be answered. So if there's a question that you have, that comes up during this presentation that doesn't get answered, make sure to utilize those Q&A sessions. Without further ado, we'll go ahead and pass it over to Christy Granger from CEICMH to start us off. You can go ahead and take it away, Christy.
All right, thanks, Olivia. Hey, everyone. Happy Friday. Like Olivia said, we're going to spend some time on NGRI. This is going to be a really quick overview because we will add Scott into the mix as well with Q&A. And this is a topic that there's lots to talk about and lots to share. So I'm really going to just focus on kind of the practicalities and what CMHs are responsible for and or if you're contracting with another provider. So we're going to quick go through the contact information, some legal terms, and the risk mitigation. Most of you know where the Forensic Center is, but this actually is a booklet that I use to train our folks here at CEI. So this is some basic information. The contact people for the NGRI committee is listed here. And I believe, Olivia, we will be able to share this with people afterwards. Is that correct? Great. So you guys will have this. Just some legal terms, just so that people are clear. I think most people know that IST stands for incompetent to stand trial. NGRI is not guilty by reason of insanity. And then there you'll see people under a civil probate order, a maintenance order, and NGRI diagnostic. So I'm going to really focus on the risk mitigation strategies. For a few of us that have been in this field for a long time, this used to be called we're used to it being called the contract, the ALS. In recent years, this has been changed to the risk mitigation strategies. This risk mitigation strategy is something that should be developed with not only the regional hospital or if they're in CFP at the time, but also the CMH. It's really, really important that this risk mitigation plan really be started as soon as they are admitted. Now, I understand like folks are not doing well, what have you, but it's really important that CMHs are involved and able to tell NGRI committee what resources that they have available in their community and what, because oftentimes in these risk mitigation strategies, it speaks to what is going to be provided to the consumer. It could be a supervised setting. It could be a secure setting. They may recommend like an ACT team. They may recommend payee, all of these things. And lots of the communities don't have everything that other communities have. So it's really important that the CMHs are coming to the table with CFP and or the regional hospital to develop these. Each regional hospital, their forms look a little bit different, but in general, every individual on NGRI shall be coming out on a risk mitigation strategy that should also match their IPOS. All right, so people ask who, and this is ours too, but who is the oversight team? We always get this. So the oversight team for individuals for us, for example, at CEI is our state hospital liaison, our forensics liaison, and then our supervisor here at community mental health. I know that each CMH does it a bit differently. Not everyone has a state hospital liaison. I know many of you are working on an AOT team. So it's really important that each CMH has an oversight team. It may be that you contract out with someone or your case management team, but it's critical that we have these teams in place because there is a lot of oversight that needs to happen with NGRI. All right, so the guidelines. So I really need folks, a lot of people aren't aware of this, and I hope it's getting out there more and more. In order for an individual to be and remain on NGRI, they must be on an AOT. If an AOT is not in place, there is no NGRI. Okay, so that's why it's so critical that we are following these cases and we understand the paperwork guidelines, all the logistics related to that. All right, so here are the reports. And like I said, this is a really quick overview today. We could take a whole day just on NGRI, but super quick. So for an individual who is in a regional hospital, Carroll, Walter Reuther, Kalamazoo, when they are discharged from that facility, they are considered what we call a standard NGRI discharge. Those individuals are required to have a 90-day report, a 180-day report, a 270-day report, and a 365 report. This is where it gets a little confusing. These reports are based on their AOT dates. So when an individual, say most of them coming out to you should be on a year order, that 90-day report, that first report that's due, is based on 90 days after the AOT is initiated. That report is the only thing, it only goes to the NGRI committee. A 90-day and a 270-day report is not required to go to the probate court. But when you move on and you do a 180-day report, that is considered the 6-month review. That should be going to probate court and the NGRI committee. And that is the same for the 365, which would be the petition for continuing treatment. That is as well should be going to the NGRI committee and probate court. Okay? The difference is then you move over to, we sometimes have these direct community placements, and I don't know if many of you have experienced that, where they're at CFP and they don't transition over to the regional hospital. They go right from CFP maybe to foster care or to live with their family. They have additional reports that are required, and those are based on their discharge from the CFP. So for those individuals, the date that they are discharged from the CFP, they are required to have a 30-day report, and then a 60-day report, and then a 90-day report. And then it moves on to the 180, the 270, and the 365. What gets complicated in there is, remember, you also have your AOT and your regular reports. So then it may be that your person has a 90-day report due July 1st, but that's their third, but then July 31st or whatever is their third 30-day report. So that's why it's so important to keep track of those. I don't know how, most people, I have a very specific spreadsheet, Excel spreadsheet, and that triggers all of this so that we can keep track of those things. So, and here's just an example of what the reports look like. I want you to be very mindful. These reports really need to be detailed as possible. Sometimes we'll find that someone will put present mental status stable. Remember, we are reporting to the NGRI committee how this individual is doing in the community. It's critical that we let NGRI know about any med changes, that we're updating them on changes with their mental status. How are they doing in the AFC? Are they secluding themselves? Are they getting out and participating? All of these things are super important. It is the expectation, of the NGRI committee that we are accurately reporting these things. I think we'll talk about this later, but we can see in the state there's some things that have gone awry with some NGRI things, and it's really important that we are doing our due diligence to report to the NGRI committee. And I understand too that there's a lot of responsibility put onto the CMHs for individuals. That's why we continue to talk about this more. So not only do you have the report date, so you have to do your regular reports to NGRI, but you also must report to NGRI when there's a change in the treatment plan, or when there's a change, which could include like a housing relocation. It may be a decrease in services or an increase in services. You also must consult with them on that, but also we have to look at what's called LOA requests. So the rule of thumb is that in the community, anything over 8 hours must be approved by NGRI. So for example, if you have someone who is looking to go on a vacation with their family, it's going to be a 3-day vacation. It is the responsibility of the CMH or contract provider to fill out an LOA request. Those LOA requests need to be very specific as to where they're going, who they're going to be with, the emergency contact numbers, and the emergency plan. Where's the local ER? Where's the local CMH? Keep in mind that the NGRI committee only meets weekly. And so you have to time it right, because you have to give them time to review this, to get you back their approval or denial before you can allow an individual to go on the LOA. So for example, I always tell folks working with NGRI, especially like around the holidays and so forth, like if your individual you're working with is looking to go and visit their family during Christmas, get that in the first part of December. Like start getting that information out so that these things don't get delayed. Now, there are examples where you have an urgent, I recently had this, like a death in the family. You can, as a provider, urgently email the NGRI committee and say, hey, I know this is outside the time frames, this is an urgent thing, and they will come together and deny or approve that. But it's really important that you're doing this. Without these forms, we have no documentation. You have to have that approval. Just like I said, you have to have approval about the changes in the treatment plan. They're not necessarily going to approve or deny like the medication changes, because they're not the working psychiatrist at the time, but it's really important that you notify them of medication changes, because had been working with the individual, and if they start to see signs of decomp or whatever, they may be able to weigh in and say, while they were here, this is what they did really well on. Maybe you'll want to go back to that. So that's what these forms are used for. For those of you that don't know, there is the Not Guilty by Reason of Insanity handbook out there that you can refer to. We also have the AOT toolkit that everyone can look at, that gives you the forms, gives you instructions. It's a very helpful tool out there. trying to think what else there. I mean, like I said, this is a super quick overview today. Just keep in mind, if nothing else, we are responsible for those individuals out there in the community. It is our responsibility to ensure that these forms are done. We have to report changes, any type of involvement with law enforcement, any changes in mental status, even when it's outside of the reporting time. So keep that in mind. If you have a situation where an NGRI consumer over the weekend was arrested, it is your responsibility to let the NGRI committee know that next working day. If an individual has eloped and you haven't seen them in after the 8-hour period, you need to let them know. It's your responsibility as that provider. I also want to point out that the NGRI committee also is open to questions. People always say, well, who are these people? Where do they sit? What do they do? They are a committee that is assigned by the state through MDHHS. They're comprised of psychiatrists, psychologists, social workers, what have you. And they are there, they are a support as well. So keep that in mind, that if you have questions, reach out to them. Oftentimes I've said, hey, we're having a really challenging individual out here in the community. We've tried X, Y, and Z. Nothing is working. They don't believe that they, signed anything, that you never educated them on this. We get that all the time. And we've had it where the NGRI committee will say, you know what, let's have a meeting with them. Let's get on Zoom. Let's talk to them. Let's all get on the same page. And so they will do that. I always say, use them as your friend, use them as your tool, the community. Because people do get confused where they believe that once their year is up, they're done. Where that confusion comes in is with that AOT. Remember, we gotta keep in mind that in order to be an NGRI, you have to be on an AOT. That AOT is reviewed yearly. So often consumers think, oh, well, when that review comes, the doctor's just going to take me off that AOT and then I won't be on NGRI. So that's where they often get confused. So just reiterating that with the consumers that this is a review. The expectation is that you will be on this risk mitigation strategy in AOT up to 5 years. Okay, and I know we're going to take questions and answers, but I want to Q&A, but I want to leave time for Dr. Smith to talk further.
Thank you so much, Christy. Appreciate the overview. Yeah, we can go ahead and pass it off to Dr. Smith now.
Great. Thank you so much. I want to briefly start with a little bit of an elaboration of NGRI, especially for those of you attending today who might be very new to this concept, or those of you who have maybe always had some questions, and this might answer some of them. And just a note, I'm more than happy, as is Christy, to go into greater detail during our Q&A. But the general overview is this, that NGRI, or not guilty by reason of insanity, is a type of plea that you enter when you're accused of a crime. Now, we refer to this type of plea as an affirmative defense, meaning you're not denying guilt, but responsibility. And this is critical because you are admitting guilt, and the process then to determine whether you are, in fact, going to qualify for NGRI is determined after that through an evaluation process. And pick any 10 criminal defense attorneys and you'll get 10 different opinions on this, but it's worth noting that there is a pretty big divide around what the most appropriate use of this legal defense is. And I think all of us have been exposed, if not in fictionalized accounts, then in very real news stories about how NGRI cases might be mishandled, both people who clearly met the case or the standard didn't receive it, and in other instances, individuals who appeared to have maybe manipulated it. But it's important to note that in actuality, there's quite an elaborate evaluation process that has to occur by specially trained forensic personnel. And what they're looking for is essentially, was this person at the time of the crime able to form intent? Did they actually know and understand what their actions were? And so the eligibility is typically, for individuals with a serious mental illness, those with some type of developmental disability, and this can include cognitive impairment. It's worth noting a lot of this is historically established case law from the Supreme Court decisions, things such as using an IQ of 70 and under as a way to determine essentially that the person is incapable developmentally of being able to, you know, be charged and participate in a criminal proceeding. This also includes things like neurological injuries. We're going to come back to this a little bit later because this has a lot of impact as we take a look at shifting demographics. Now, for individuals being evaluated for NGRI, typically, they're going to be confined during the evaluation period, and if the court accepts the NGRI plea, then there will be confinement and treatment until determined safety, community reentry goals are actually met. So how long will somebody be confined? It depends on how well they respond to treatment, depends on a variety of factors, right? And then after they're released, there's monitoring that's necessary. And this is primarily to prevent recidivism. And again, when we're talking about presenting recidivism here, what we've already acknowledged is that for somebody who met the criteria for NGRI, they weren't necessarily intentionally going out and committing a crime, right? That intent piece isn't there. So we have to kind of think of recidivism as being substantially different than how we normally talk about it in criminal justice circles. Now, I want to kind of go into, an elaboration of some of what Christy has shared and what some of the current concerns are. Some of this is Michigan specific, but a lot of this is actually very much a part of a national conversation. And Michigan's laws, at least regarding eligibility for things like not guilty by reason of insanity, parallels laws in many other states. The difference tends to be in how cases are handled. The first issue that we're going to address is really how we're seeing more and more an intersection of criminal and civil actions. And the common ground there is going to be the use of assisted outpatient treatment orders. We're also seeing a lot of expansion of AOT without necessarily expanding our workforce. So especially professionals who can perform the evaluations and those who can also testify. Our current law has some pretty specific requirements for both. And I'm going to talk to you in just a moment about some pending legislation, which will change a little bit about that, and maybe some ideas for how we can, address this problem even beyond current legislative efforts. One challenge that we do currently face is that our law assumes that an evaluator is competent based on their degree, not necessarily that they have specific knowledge or training. And, one thing that we know to be true is that many individuals, most of us working in this field, we've got a lot going on. We're busy, and that busyness doesn't show any times of ending. It's very easy to fall behind on legal changes. It's very easy to, especially for those of us who are more experienced, we'll go with. We've been in the field longer. Early learnings are the most powerful, the most pervasive for us, and it's very easy to kind of revert back to our earlier learnings, even if we do become aware of certain legal changes. So, for example, a couple of weeks ago, I was having a conversation with a employee at a emergency department. I was helping to advocate for an individual in need of treatment, and this employee was explaining that because the person didn't explicitly say they wanted to hurt themselves or somebody else, they couldn't be petitioned. And this was a teachable moment. I had the opportunity to kind of explain and even point to the form and kind of educate on how, thankfully, back in 2019, 2017, for some of it, we changed these laws. And what was clear to me was this individual was a competent professional, had a lot of experience, but found themselves victim to that same risk of what happens to all of us when we're in a field for a long period of time. We presume we have a level of understanding and competence, and until that's challenged, we don't really know what we don't really know. And then the final thing we're going to briefly chat about is the idea of incompetence to stand trial, IST. Current rules and how changing demographics are really making this an area that already doesn't get enough attention, but now it's getting into a very critical area for this lack of attention. So part of what Christy was explaining about the rules around, for CMHs around individuals released with NGRI status goes back to a 2021 settlement between Disability Rights Michigan and the state of Michigan. And essentially, what it was really centered on was how the current structure at the time, that is authorized leave contracts, authorized leave status contracts specifically, offered blanket restrictions, but not those that were specific to the individual. And so very often they were violating, arguably the individual's civil liberties. So they might be restricted in when and where they could work without regard to the unique nature of their mental illness and why they were on NGRI to begin with. So part of the lawsuit settlement, where the state did not acknowledge any wrongdoing, but rather said, here's what we're going to try to do to amend this problem. Essentially, they replaced those ALS contracts with a plan to place everybody on an IPOS, and individualized plan of service, and use AOTs as the mechanisms to ensure that individualized, plan was being carried out. Now, it's worth noting that the lawsuit brought by Disability Rights Michigan is very similar to other lawsuits, specifically the Ross versus Inslee case in Washington State that goes all the way back to 2014. Now, the outcomes were somewhat similar, but it's important to recognize that very different NGRI laws exist in Washington State than exist in Michigan. And one thing that I think Michigan and other states could benefit from would be things like a public safety review panel. Volunteers appointed by the governor who provide a fresh set of eyes. Typically, they need to have expertise in criminal justice, law enforcement, mental health, etc. And they provide an alternative perspective, can ask questions, kind of check and balance system. They also assigned a designated ombudsperson who is responsible for helping individuals released on NGRI status to advocate when they feel like they're being unfairly limited by the terms of their NGRI release. So these are some great opportunities that we could look at actually implementing in the state to enhance this process overall. Now, the main consequence of this was that it shifted much of the burden from the state hospital to the local CMH. And by tying NGRI status to AOT, it also places this greater legal and ethical responsibility on the CMH. Setting aside things like these clients are more likely to have very high acuity and much more need for close supervision. Why? Well, because the nature of how they got into an NGRI situation meant that they weren't able to recognize that their actions would lead to breaking of a law. And obviously, in some instances, the laws broken included violence and significant loss to others. So to say that these clients have higher acuity is an understatement. It also puts the CMH in a position where, as the statutorily responsible party for AOTs, they now assumed a lot of culpability. So if an AOT order is not renewed, like Christy explained, that NGRI status and support is lost. And heaven forbid that that individual, again, commits a crime, ultimately culpability could fall now onto the CMH. We also need to be the fact that this and some other things are really kind of blending criminal and civil law in ways that should make us push pause a bit. Now, I want to be very, very clear that I am all for every single thing we can do to divert people living with mental illness away from the criminal justice system. Um, this has been a horrific way for us to treat individuals living with mental illness. I think everybody, and I mean everybody now, is on the same page that, like, this is not how we want to handle things. But I do think we need to proceed very cautiously. So not only do we now have somebody convicted of a criminal, act being released and supervised in a under not criminal court supervision, but civil court supervision. But we've got multiple pieces of legislation introduced to expand this further. The current one, Senate Bill 221, I just wanted to highlight that. I put, the link to that bill and the language there at the bottom of the slide. Couple of key points to note is that the evaluation in this case applies to individuals who have committed a misdemeanor and whether the court believes that the person did so as a result of their mental illness. So the courts are really driving this and holding most of the criteria. There's no need for specific forensic training, and it's unclear how courts will make this determination, if they'll hire their own professionals or use outside consultants. But essentially, anybody who can complete a cert can complete this evaluation. And again, while this is a great opportunity for additional diversion, it does raise other questions, such as, well, this is going to put even more burden on our overburdened CMHs. It's also unclear how much more beneficial this is than existing opportunities through specialty courts like mental health court, right? So in many jurisdictions, somebody with a mental health concern can be put into a different, court structure where, with treatment, they can have their charges dropped. This accomplishes something similar, but does so by exiting the criminal court pretty much entirely. And again, this bumps into the issue that we're now expanding AOT even more, but our workforce is not growing nearly fast enough to keep up with existing need, and we're not expanding those who can evaluate and testify. And there is good news on this front that we have, legislation pending that would allow mid-levels to do a lot more, specifically completing certs, but they're not going to necessarily, based on current changes to the legislation, be able to testify yet. And I know for psychiatrists, this is a huge burden. It's also an unbillable burden, which adds financial constraints to the time constraints. It's also worth noting that this expansion is, again, degree-based, and it doesn't necessarily guarantee that those with the degree will have sufficient understanding of the law. I've worked with many mid-levels over my career, love and respect them, but the amount of training and their background is often very different. And this law does not necessarily guarantee that that individual will have sufficient training. And while nurse practitioners, psychiatric nurse practitioners specifically, do have a very specialized curriculum, PA's training in general includes very minimal training in psychiatry. They need to gain that afterwards. So it's worth, noting that maybe this is, a potential problem we can get ahead of. And the other thing that comes up here is when we compare AOT to guardianship, guardianship is much more restrictive, but the professionals who can evaluate somebody for guardianship is much broader. And it's curious why it's not more comparable. And a possible solution here is the use of a certification program, where instead of just saying that because of your degree, you can do this, that you have to demonstrate that you have the specific knowledge, skills, abilities to do this. And, there are models for this in other areas, even other areas within our own state. So this could potentially be a solution to look into. Now, finally, I want to talk about incompetent to stand trial. And briefly, when somebody is determined to be incompetent to stand trial, it's referring to their ability to understand the crime they're being charged with and participate in their own defense. Now, somebody can be found incompetent to stand trial for a broad set of reasons. Many of these are temporary, transitory, can be effectively treated, and competency can be restored. On the other hand, there are individuals who will never be competent to stand trial due to, let's say, a severe traumatic brain injury or some other kind of neurological disease that is progressive and is unlikely to enable them to ever be able to, understand and participate in their trial. Now, one thing we know is that over the past decade, referrals for evaluations for incompetence to stand trial have more than doubled. So this is worth, considering because, again, we're already short-staffed. This has placed an enormous burden on, specifically the Center for Forensic Psychiatry, and a very small number of our mental health professionals in the state to handle this. And this is to say nothing of what current demographics tell us about our likely future, and that is that we have an aging population and progressive, diseases such as dementia would meet this qualification in some instances. We also have, a growing population of children living with some type of developmental disability. And as they become adults, they too could be eligible for, this should they be involved in, some type of criminal trial. We have a few different restrictions here compared to NGRI. There's a maximum hospitalization for incompetency to stand trial. A person can't be held for more than 15 months or a maximum of 1/3 of the maximum sentence for their crime. So for some individuals who might have restorability or making progress towards that, we now have a pretty tight time limit. If that can't be achieved in that 15 months or 1/3 of their max sentence, we still have to help them re-enter the community. And we have to do this by considering, like, how do we support them? How do we keep them safe and healthy? How do we keep the community safe and healthy? And this brings up the kind of the final note here, which is the concept of LRE, or least restrictive environment. The expectation is that for both NGRI and IST, when those individuals are being treated, it's going to occur in the least restrictive environment. Now, sometimes this is interpreted as being outside of a hospital setting, but when we compare this concept to the concept as it's used in things like special education law, least restrictive environment means the environment that will also present the fewest challenges, leading to the individual not being successful. So this, I think, is an area where we have an opportunity for a lot more discourse and considerations of how do we move forward with the current set of challenges in a system that both recognizes the dignity and worth of the individual and helps them to be successful while meeting the legal expectation of creating community safety. So on that note, we'll go ahead and transition into our Q&A time.
Wonderful. Thank you both so much for, what feels very comprehensive, but also we all know is very like much scratching the surface of NGRI. So thank you both so much. So I just wanted to address that Megan in the chat had asked, if PAs are able to complete a cert for initial petition in cases where we seek law enforcement to transport an individual to be examined. And that was answered in the chat. There is a legal standing to say that, but the decision is up to the judge if he or she or they accept that legal stance. With the law, being interpreted in different ways, that's why we have the appeals process. So thank you so much, Megan, for that question. And yeah, and I see Megan has her hand up. Megan, you have the floor.
Hi. Yeah, so I just have a quick question. So in some of the documents that I've read, it talks a lot about the role of the supervisory level forensic psychiatrist. So I just had like in regards to like we obviously our providers manage our individuals who are NGRI and provide that assistance, but are their psychiatrists supposed to have a certain type of training to meet that supervisory level forensic? That's just thrown me off. So I just didn't know.
Sure. Christy, do you want to speak to that one?
Megan, just to clarify, are you referencing at CFP or are you referencing at CMH as like the providers?
I'm sorry, CMH, the providers that we contract with.
Oh, yeah, no, there's nothing out there that specifies that to my knowledge. The individuals who are doing the evaluations initially at CFP have to have that specific training, but the individual supervising this care, like the supervising psychiatrists, are not at the CMHs. There's nothing that I'm aware of that states that they need to have that specific forensics training, and none of ours here do.
Okay, perfect. Thank you.
Wonderful. Thank you.
To clarify, I believe Megan is talking about the APF 106, and that's the state of Michigan's policies and procedures. And so that language is specific for the hospitals and state employees.
Sorry, I have one more question.
Don't apologize. Go ahead.
So when I have here at OCHN, we have been really trying to get a better handle of NGRI and understand the process. So when I've connected with our providers like Easter Seals, TTI, CNS, a couple of them have mentioned that previously when they would connect with the NGRI committee, the response was fairly quick. But as of late, one mentioned, I mean, it has been weeks and weeks and she's not getting a response. So Christy, I know you had mentioned that you can email and they'll get back to you quickly. So I didn't know, is there some type of time frame that requires them to like, do they have to respond in a certain time frame, or is it just pretty much whenever they meet?
Well, I think it's situational. So from our student, they do meet every week. And so for like the reports and for like the LOAs and stuff, those usually, and I'm not sure where maybe where the issue is, but they have, like, I don't know if you get the response from Deb Brock, but she'll say, typically they'll meet on, is it Tuesday or Wednesday? I'm sorry, I don't have it right in front of me, but we'll have a response by Thursday or Friday, and Deb will say, hey, I'm running behind, I'll email you on Monday. So as far as the turnaround, if it's in before noon on Tuesday, as far as the request and reports, you should be having a response by Friday or Monday. If it's that last minute, it's an urgent thing. I've been having them respond 24 to 48 hours. But what I do know from Kelly Schaefer is that the number of NGRI cases and folks and what the committee needs to review each week is actually taking them more time than they've ever had to. And often they have to convene another time a week. So that may be where some of the problems are, but typically they're really quick about responding.
Thank you. So, but there is nothing in any type of code. It's like you respond by this date, whatever.
No.
Thank you, Megan.
Are folks aware, I guess I want to point this out, when you're doing the AOTs, making sure that they're combined AOTs, because we often run into, because it used to be that when individuals were on what was the ALS, you were finding that folks came out of the hospital on a hospital only order because technically they were still a consumer of the hospital, and so it was a different type of order. And so probate judges got very accustomed to making sure that the NGRI orders were a year hospital, and it's really important to be aware, because if you don't have a combined order, then you'd have to, if you needed to do the outpatient or the inpatient, you'd have to get that amended, dependent or modified, depending on what you were looking for. So just really important that when your folks are coming out of the regional hospital, that you're verifying with the regional hospital that the order is a combined order when they're released.
Right, so I have a question about that. If in the case they were on an AOT only, wouldn't that still allow for the 10 days of or the 2 weeks of hospitalization built in within that order if the patient did need to be hospitalized?
It would, but it's only going to give, yes, it's only going to give you that amount of time. So it is best if you, yes, if you did that combined.
Okay.
Yeah.
But could the order, hypothetically, if this already happened, could the order be amended to then request a combined order and ask for additional hospital days?
Yeah, so what you would want to do on that is do the notification of non-compliance and request that modification, yes.
Okay, thank you.
Mhm.
Okay, so before we wrap up and take any final questions, I want to make sure that we share um, the resources that we have on the toolkit. So this first one, we have the NGRI overview brief, or I'm sorry, this is the checklist for providers. So we have the NGRI checklist for providers. The purpose of this document is to guide mental health providers in tracking and completing required documentation and reporting tasks for individuals who are not guilty by reason of insanity, NGRI. It outlines key deadlines, required forms, clinical responsibilities across different stages of the care spectrum, especially after discharge from the state hospital or the forensic center. So the checklist ensures compliance with legal mandates, supports risk mitigation planning, and helps coordinate communication with the NGRI committee and relevant oversight bodies. So I'll go ahead and drop the link to this in the chat, but yep, this is on our AOT toolkit. And then we have just kind of an overview brief, as you can see here. The purpose of this document is to provide a clear and comprehensive overview of NGRI process, including its legal criteria, treatment pathways, and oversight mechanisms. It aims to help the general community understand how individuals who are found NGRI are assessed and treated and monitored within the mental health and legal systems. Okay, wonderful. Well, thank you so much, Dr. Scott Smith and Christy Granger, for coming. Thank you all so much. Again, if there's any questions that come up later, be sure to check out those AOT Q&A sessions with Dr. Scott Smith. Thank you all so much. Have a great weekend.